Hello everyone. Our next session is with infection prevention and control, and we will be discussing CAUTI events. Hopefully that's a term that is familiar to you, but in case it isn't, we will just review quickly what is a CAUTI. It is a catheter-associated urinary tract infection. It is a common type of healthcare-associated infection, and it is associated with increased morbidity, mortality, increased healthcare costs, and increased length of stay for the patient. So what causes a CAUTI? There are microorganisms that get into the patient's urinary tract, causing this infection. They can enter, how they get there is either endogenous, meaning from the patient, or exogenous, which would be from maybe a contaminated piece of equipment, maybe the Foley catheter tray during insertion. Something happened along the lines where sterile technique was unable to be followed and unfortunately caused some sort of contamination. It can also occur through contaminated hands of the healthcare worker. So when these microorganisms are introduced, it can either be extraluminal along the outside of the catheter or intraluminal, which will be on the inside of the catheter. A couple of examples of all of these items would be if a healthcare worker comes into a patient's room, they miss an opportunity for hand hygiene. They go in and help the patient, help reposition them in bed, reposition their Foley catheter just so all the urine is flowing well, keeping those dependent loops out. If they miss that hand hygiene and their hands are contaminated, unfortunately they may be introducing microorganisms to the outside of that catheter. Another example would be if healthcare workers in the room, they're emptying the Foley catheter, emptying the drainage bag into the collection container, and say the tip touches the side. You may or may not know if that's contaminated or not. So when that tip touches the side, you are potentially introducing microorganisms onto that Foley catheter on the inside. Now you may not be able to see these occurring. Obviously we're not going to see the microorganisms, but this next. So how do we know if someone has a CAUTI? In infection prevention and control, we review daily microbiology lab results. This would be all kinds of cultures that we get, but specifically for this type of event, we look at all urine cultures. From there, we look to see if it was an inpatient, and then we also look to see if they had a Foley catheter in. If they have met all that criteria, then we continue to look further to see if during a certain time period they had a fever, or if there's documentation of suprapubic tenderness, or if they had CVA, pain or tenderness. Once we have identified this event, we will notify the unit that it is attributed to. Also, what we do is we report it to the National Healthcare Safety Network. That is a network that is used nationwide by most healthcare facilities. It is a way for us to enter our information and track it and kind of see where we're at compared to other facilities of our same size. We also put it into NHSN because then from there, CMS can pull this information and they use that for required infection reporting. So why does all this matter? First of all, patient safety is why we're looking for this and trying to do what we can to prevent this. But also, as I mentioned on the previous slide, CMS pulls this data and they score us as a facility on that, and that is publicly reported. They also link our Medicare payments based on our data. So, and we're not just looking at CAUTI events, but they also look at central line associated bloodstream infections, any type of surgical site infection, ventilator events. So this is how we report the infection requirements. CMS also looks at other events such as falls and pressure injuries, and they have another network that is reported under. But this is just kind of a piece of the puzzle that CMS uses for scoring us, getting that publicly reported, and then also linking our Medicare payments to that. Just to give you a little bit more information on that, there is a hospital-acquired condition reduction program. It's kind of a pay for performance, so the better we do, the more of a reimbursement we will get. If we are not doing so good, we may get to the point where we don't get reimbursed and we may have to pay in. So just something to keep in mind there. So how are we doing as a facility? At Trinity Health, in the last few years, we've kind of been up and down. You can see in fiscal year 2019, we had 3 events, then we went up to 7 events, 6 events in fiscal year 2021, and now for the current fiscal year, we have 2 events. So that our fiscal year runs from July 1st through June 30th of the next year. So we're halfway through the year, a little over halfway through the year, and we have 2 events so far, which is pretty good compared to our previous couple years, so hopefully we can keep that up. Just to keep in mind, the average cost of a CAUTI event is over $13,000, and that is a cost to us as a facility. That is not anything that the patient pays for. So where do we go from here with all this information? Well, we need to make sure we're doing everything we can, obviously, to prevent these events, and one thing we can do is to assess our patient's need for a urinary catheter. There's obviously appropriate reasons, which would include urinary retention or obstruction. If genitourinary surgery or someone from urology placed the catheter, we of course want to leave that in. Patients that have open sacral or perineal wounds, critical illness, specifically the patients in ICU that have that strict I&O, they're monitoring hourly urinary output, definitely need to have the catheter in for that. And terminal illness, so patients that are receiving comfort care. Inappropriate reasons would be placing it because someone is incontinent, if we need a specimen collection, convenience, or patient preference. And remember on that patient preference, just remember to educate your patients, explain to them their risk of infection will go up every day. Remember, it's at 3 to 7%. And we truly want to get them back to where they were prior to admission for most patients. That's our goal. So very important for us to be assessing the appropriate needs of the urinary catheter for the patient. So we do have a nurse-driven urinary catheter removal protocol. This is the form that contains the appropriate reasons that were on the previous slide, and this is to be assessed twice a day, so every 12 hours you'll be filling this out. That is one way we can kind of keep track of necessary placement. Also, we can look at, is there an alternative? So we all know that for females, we have the external catheter that's called the PureWick, and then also for our male patients, we have it's called the Spirit, but it's the condom catheter. So these products aren't for everyone, but we should at least try to assess and see if these would be appropriate for our patients. Other things to keep in mind for CAUTI prevention: during insertion, make sure we're using that standardized insertion kit. It's numbered, tells you step by step what you need to do. Don't forget to do your hand hygiene. Make sure you're not introducing anything to the patient. And then also do that perineal care prior to insertion, so we can do everything we can to avoid having any new microorganisms introduced. Follow that aseptic technique and sterile equipment. Keep everything sterile. Use the securement device, which we're using the stat locks right now. For maintenance prevention, make sure we're using that the nurse-driven protocol checklist daily. We're doing that twice a day. Make sure even for maintenance that we're doing hand hygiene anytime we are going to be coming in contact with that Foley catheter. Again, maintain that closed drainage system. Make sure that red seal is intact. If that red seal is missing, that means that it was broken, and at some point in time the catheter became disconnected from the tubing, which I know in certain circumstances that has to occur, but for the most part we should not be using that. We should try and use a whole closed drainage system where that red seal is in place. That tells us that everything stayed in place and nothing was introduced at that point. Make sure we're avoiding dependent loops. As I mentioned before, you want to make sure that the tubing is not kinked in any way and that it's not placed in a way where the urine has to travel up, because that's not the natural flow of it. It will eventually stop and just stay stagnant in the tubing there. Remember, the position of the collection bag has to be below the level of the bladder. Make sure we're using a clean collecting container. And then let's remember to do our perineal and catheter cares at least twice a day. And in the end, also remember to just stay in touch, keep communication open with you and the providers, educate your patients and their families, and then when you're reporting off at the end of your shift, make sure that this discussion is held with whoever you're reporting off to. Keep the patient in mind, and let's try and do everything we can to prevent these infections from happening. If you have any questions, you can always contact us, and I thank you for your time today.